The following is a conversation. It has the features of any conversation, such as imperfectly expressed thoughts, ill-considered opinions, and the notions of several sleep-deprived brains. Try not to get your stethoscope in a twist about it.
What do you call a whole bunch of chess enthusiasts bragging about their chess games in an empty hotel lobby?
Do tell.
A
Fallon.
convention.
No, well, I guess, but chestnuts boasting in an open foyer.
Nice.
Well played.
I thought that one was good. Okay.
Very nice. Dr. Yurkiewicz, have you seen the latest drop from the Zach and Fal YouTube channel?
I have not, no.
Our own Fallon Jung here, who you met last time.
Yeah.
She and her significant other have a YouTube channel where they have traveled the world in a van.
Yes.
And they just dropped their Mexico trip, Baja Mexico trip. And I thoroughly enjoyed watching it. You were having fun with friends. You were eating foods, incidentally throwing
Getting
up
rid of
those foods.
Yeah.
I just want people to go and listen to it because you guys are super cute.
Oh, man, that is really cute. Thank you.
And
There's also some fun Halloween skits.
Yeah, I was
on
about
there,
to say,
too.
check out the Halloween skit.
Oh, my
Yeah,
goodness.
yeah.
Wow.
So anyway, you should check it out.
Our own celebrity right here.
Yeah.
Influencer.
I'm feeling a little blushy.
Meandering in the margins of medicine, it's the Shortcoat Podcast.
Weird news,
fresh views,
helpful clues, and interviews.
by students, for students.
Subscribe to our weekly show at theshortcoat.com.
Welcome back to the Short Code Podcast, the show that gives you an inside look at medical school from the students drinking from that fire hose. It's a production of the University of Iowa Carver College of Medicine. I'm Dave Etler. With me today in the SCP studio, a special guest returns. Dr. Ilana Yurkiewicz is co-director of Stanford University's Primary Care for Cancer Survivorship Program. She's a science journalist and the author of a new book entitled Fragmented, A Doctor's Quest to Piece Together American Healthcare. And you are here for our November 9th episode, and we all wanted to ask you to come back because we had such a good time talking to you. Welcome back to the Short Code Podcast.
I had a great time too. Happy to be back.
And of course, I have a crew of CCOM students who have joined us today. It gives me great pleasure to tell you that we're joined by M2 Jeff Goddard.
Hello.
I'm over the moon about the presence of M1 Fallon Jung.
Hi.
I've never been happier that MD PhD student Jacqueline Nielson has arrived. Is that right? MD PhD?
Yeah, hello.
I thought so. And what joy. We're joined by a new co-host, M1 Alex Nigg.
Hello.
Welcome to the show.
Thank you.
Before we start, I do need to take a second. I want to take a second to thank Stacy in North Carolina. She brought a sticker and made a donation over at theshortcoat.com. She says the podcast is helpful in supporting her kid on her journey to medical school, which makes me very happy. Moms are pretty much the only ones who have ever donated to the Shortcoat podcast that I can remember. And I love that. I love moms. Moms are great. Stacy, if you or your future medical student ever have any questions, we're here for you. Just drop us a line at theshortcoats@gmail.com.
Thanks, Stacy.
She rocks. Dr. Yurkiewicz, again, thanks for returning to the show. And listeners, you'll want to go back and listen to part one of our conversation. As I said, it was from November 9th. If you haven't already, go to theshortcoat.com and look that up because we had a great conversation about the challenges patients have in maintaining a consistent doctor-patient relationship, the shortcomings of electronic medical records, and the other ways we try to keep track of what's happening to your patients, and the need for better care continuity and coordination, particularly in cancer treatment.
Thanks. Looking forward to part two.
I just wanted to say, as a partner of someone in cancer survivorship who has had a really hard time finding continuity of care, even within one institution, it gives us so much hope that you started this clinic and have this model, and hopefully it grows to other institutions to really fill in those gaps.
Oh, well, I so appreciate you saying that. I think there's a huge need for this model. I don't want to be the only person doing it. I talk so much about this model because I want the next generation of med students and residents to do something similar. And I know it fills a huge need. So thank you for saying that.
Thank you.
So I guess my first thought, one of the phrases that hit me I don't know, it's like a bus, when I was reading the book. It was the chapter where you're talking about medical students doing their like mobile clinics. And you talked about how that was a safety net, but then you said the line that that these safety nets, they have holes and that people fall through those holes. And that was very impactful as somebody who has definitely benefited from safety nets in my life, and also probably fallen through some of those holes, especially as a child. It got me thinking a lot. I mean, I don't want to stretch the analogy too much, but like, how can we design better safety tarps that there are fewer holes for these types of things? I mean, we're talking about, cancer survivors are definitely people that fall through the cracks, right? But there are a lot of people, especially people that don't have access to primary care, that we've created these safety nets like these mobile clinics or these like free community outreach programs or what have you. But like you said, there are holes. How do we design a tarp that people aren't falling through the holes?
Yeah, I like that analogy. I don't think that's stretching the analogy too much at all. So I wrote about the safety clinics in particular when I was a resident, and I was rotating through a safety clinic where the med students would see patients and then staff patients with me and other physicians. And the very first time I went there as a resident, I kind of pulled up into the parking lot and, I typed the address into my GPS and realized that I was actually heading to a school, and it was a classroom that was doubling as an exam room. And so I kind of looked behind the basketball courts, figured out where I was supposed to go, and realized that was the clinic. And the safety net was an amazing resource for these patients who often did have nowhere else to go. We saw patients who had put off receiving care for financial reasons, sometimes for many years. I tell a story in the book about seeing this couple from Nigeria where both of them had problems. The man and the woman both had problems that really needed to be urgently treated. The man was complaining about constant urination, and after doing a physical exam with the med student, we suspected that he might have prostate cancer. And she had been complaining about blurry vision, and after doing a physical examination, we suspected that she had cataracts that needed surgery. And we kind of made our diagnoses, and then came the next huge hurdle, which was how do we actually get them the care that they need for these next steps? So I thought about what I would do. Let's say if I were in my clinic, I would order a PSA, a blood test on him, a urine test. And if either of those came back suggestive of prostate cancer, I thought about the next steps, which would be possibly a pelvic MRI and a biopsy. And what I realized was, we could offer some of these steps, but then the next layers would be so onerous to get these patients care. Like we could order a blood test and a urine test, but suppose those came back suggestive of prostate cancer. We still had to connect these patients with a physician who could provide them ongoing, regular, continuous care, whether that was an oncologist or perhaps a primary care doctor, or in her case, perhaps an ophthalmologist. And so what I realized in the safety net was we can provide these intermediate steps. We can be a bridge between someone who is getting perhaps no care, but the ultimate goal is still to connect people to someone. And I put someone in quotes so many places, when I write about this, because you still need that continuous physician who can then provide the next steps. And I think the safety net, currently can serve as that great intermediate step. It's like a bridge. But the bigger hurdles were getting people insured and connecting them with a system that saw people who couldn't afford to get care. And I think that's, a larger question about how we finance medicine in this country, what we should be providing people who can't afford to pay. I write in the book about legislation like EMTALA, which, without getting into the weeds too much, says that in an emergency situation, anyone can get care regardless of the ability to pay. Like if you come into the emergency room, it doesn't matter if you're uninsured or underinsured. If it's a medical emergency, you will get care. Now that's great, right? But what about the next steps? And so what happens in the emergency room to me was similar to what I saw in the free clinics. Like you can get that emergency care, you can put that Band-Aid on, you can do kind of a transaction, you can do something that's one and done. Maybe we could suture a wound, maybe we can prescribe antibiotics for a UTI, but anything that required chronic illness management, those patients would fall through the cracks.
And I think I would just like to say that as the perpetual optimist in the room, I am thrilled to live in a post 1980s, circa 1980s society where EMTALA exists, right? That patients aren't dropped off at an emergency department by the other hospital that didn't want to deal with them. They just take them to like another hospital. Like we actually take care of patients in emergency situations. I think that's a phenomenal step forward in recognizing that this is a human right. And yet there is a long way to go with it. I guess kind of as a follow-up question, and hopefully this doesn't, I'd like to say that I don't have an answer to this. I'm trying to feel out where we should be putting our energy. You said last time, the phrase that stuck with me was that good medicine is rarely one and done. And as a medical student, we want to do good. I've worked in our mobile clinic here, specifically as an interpreter for patients that don't speak English. And that's been a wonderful experience. And sometimes it is a one and done issue. Like they need glasses or eye drops, or they need to get treatment for an STI or something that is genuinely can be one and done, right? But a lot of the times, like you said, it needs more than that. And I guess my question is, mobile clinics are good. Like student clinics are doing some good in the world, but would it be more advantageous? Would it be better overall for our patients to be using some of that time or most of that time to be advocating for these long-term continuity of care, to advocate for legislation that allows for more than just one and done care? I guess I'm thinking of like that little girl on the beach that's like, the throwing the starfish back into the water. I don't know if you ever heard that parable. And it matters for that one starfish, but also that one starfish is going to be back here on the beach unless we create a way for them to not fall through the cracks again, right? So I don't know. I don't know if I have an answer to that. Just a thought.
I completely agree. And I think part of it is just how we think about medical emergencies and how we even define medical emergencies. So EMTALA was great legislation. EMTALA legislation said that you can't be turned away for a medical emergency, regardless of your ability to pay. Now, what counts, though, as a medical emergency? Medical emergencies are typically defined as those one-and-done transactions. You come into the emergency room or a free clinic, and someone's having chest pain, and you do some tests, and you rule out that they're having a myocardial infarction, let's say. But in the book, I tell a story about a man who came in and he had AML or acute myeloid leukemia. And once he was diagnosed, once the medical emergency part of his presentation was treated, which was doing a procedure called leukapheresis to lower his white blood cells, well, I would argue that getting treatment for the AML would still constitute a medical emergency, even if he didn't need to be hospitalized for that part of it. And so we define medical emergencies in certain ways. Our legislation supports that. And all of our financial resources into free clinics and otherwise go into supporting that. I would argue that we need to redefine what constitutes an emergency, and that follow-up ongoing care with a physician who can care for a chronic illness is important enough. It's as important as ruling out a heart attack. It's as important as putting a stent in and then sending someone on their way. It doesn't really make sense to me to define medical emergencies only as these transactions, when so much of medical care today is living with chronic illness, and it's living with chronic illness that needs ongoing treatment.
Strikes me. Oh, sorry, go ahead.
Well, I just sort of want to follow that, thinking about COVID and how much stress that put on our ERs and just beds in general. Were there any advances to improving this EMTALA to get people help with their chronic health conditions instead of always seeing them in the ER?
I think there was maybe some silver linings of COVID, if you could put it that way, to something that was so devastating. I think one of the things that happened with COVID, because the need for care was just so enormous, was that we expanded access to telemedicine, and we expanded access to being able to do video calls and phone calls and have that count financially as a visit. Before 2020, if you as a physician did a phone call with a patient, that was uncompensated work, it was something you'd be doing in your free time. And then after COVID, in most parts of the country, that did change. And so I think we've gotten more creative in how to care for people across the country who don't necessarily can travel 4 hours to access care. But honestly, I don't think it has truly moved the needle in terms of making that distinction between what counts as emergency care and what would qualify, as an emergency outside the emergency room, where I would still argue that follow-up care after COVID, like let's say you had COVID and you were really sick and you were hospitalized and you had to be on a ventilator, medical emergency, obviously. Now, let's say you get off the ventilator and you are chronically weak, or you have a chronic cough and you can't work anymore because of some of the sequelae that you went through because of COVID. Not a medical emergency, right? But incredibly important. And that's where I don't think we have kind of defined, in this nation, what counts as important medical care. And that's where the follow-up is just so crucial. And I think we need to be devoting as much resources there as to that initial medical emergency.
Out of curiosity, are there any rules or laws against student-run clinics or mobile clinics doing like video calls or like Zoom calls with patients that we know or that they know that they've already seen? And furthermore, can mobile clinics hold records of patients that they've seen?
So to my knowledge, there are no laws or rules that would apply to the student clinics as long as they're being supervised by a physician who follows the same rules that any other clinics have to follow. And I'm sorry, what was the second part of your question?
Can mobile clinics keep records of patients that they've already seen?
Oh, yes. So they can. And so when I worked at a mobile clinic, the student-run clinic, I had access to some records. It was a different electronic medical record keeping system from typically the clinic or hospital where I worked. So if we did end up helping that patient get insured and then sending them to a regular primary care doctor within the regular network where I worked, those records were disconnected. And so some of these are homegrown electronic medical records. But yes, student-run clinics can absolutely keep records. And that's how we can do some of those follow-up visits, even if there are still bridges to long-term care.
I think the thing that strikes me about this conversation is that I do feel like humans are very bad at coming up with systems that account for everybody, all of the possible permutations. I think that, we tend to create systems and then go, okay, we've done that, good enough, and then we stop paying attention to it. And any change that happens is very incremental over time.
So I'm going to make an argument for incrementalism real quick. First, Dave and I had a lovely conversation about what the brain is for before the podcast today. Humans are bad at nuance because the brain is lazy, and it is evolutionarily advantageous to be lazy, to kind of set it and forget it. And that's why we build boxes. That's why we have categories. That's why.
Yeah. Right? It's hard to plan for every single thing.
Exactly. Yeah. And so I think that it is absolutely wonderful that we create a system that's quote unquote good enough, and then we continue to incrementally improve it to make sure more people fit. Right.
Yeah.
As an example, the United States was founded as an idea of all people are created equal, right? And at first it was white landowners, then it was just white men, and then it was white and black men, and then it was some women got into the picture as well, and then like civil liberties started growing, and we started creating more protected classes and realizing we were building a bigger tent, right, as we go. I would be thrilled if in 1789, when they wrote the Constitution, they just like had these things already in their minds. I think the world would have been a much better place, but at the same time, there's something to be said about, and it's almost endearing to watch our species like slowly but surely be more cognizant of the fact that there are these nuances that we need to take into account, and then trying to build systems for it. But it requires such complexity that at the beginning, like it's kind of like you just have to get in the door,
Yeah, I guess you're right. You have to start somewhere.
So I think with something like EMTALA, I 100% agree. Like we get in the door of saying like, if they're going to die, you take care of them. And now we say, but that condition, they're still going to die from it, even if it isn't today. So now you still take care of them. Like for me, that would be the logical incremental step into the future. And I agree. Like, there is an ideal world, and that's not it. That's still not enough. But like a step in the right direction by recognizing like this is just what's right. Like if by not taking care of this person, they will eventually succumb to this ailment, I have a moral obligation to take care of this patient. And if we can codify that, I think that would be a good step. And I'm not against steps.
I agree. I think it sets the right precedent. Part of what EMTALA did was just define things, and it defined what we care about enough that finances were not an issue. And, we said that if you're going to die of a heart attack, it doesn't matter what your insurance is or whether you have insurance. And I think we can just expand that definition. I think we can expand that definition to chronic illness. I think we can expand that definition to the sequela of a heart attack. And, it just sets us in the right direction. And I think another thing I would say, I also kind of argue for incrementalism, because so much of what I argue and what I've argued in this book and what I've argued today is that good medicine is incrementalism. Like that, we talked about it on a systems level, but also on an individual level. Like when you're taking care of a patient in today's day and age where chronic illness is so much of patient care, there's very little of good medicine that's still one and done. Like, yes, there are still some situations where you suture a wound or you do a joint injection and you can send someone off on their merry way and they're fine and you never need to see them again. But, in my practice, so much of what I do is, let's say we start a new medicine and then I have them come back in a month. Did that new medicine work? Or we order some tests to figure out, a mystery ailment. And then I have them come back and we go over test results and maybe all the test results are normal. And now we need to decide what to do. I mean, do we keep looking? Do we just try to treat something empirically? That's what good medicine is. And this has evolved over time because more people are living with chronic illness. I talk in the book about how our financial model is essentially, it's fee for service, which goes back as far as the days of Hammurabi, where all of medicine was one and done. Like, again, you suture a wound and you got paid 5 shekels or something like that. We can't do that anymore. We just can't. I mean, whether you're in primary care,
we just got too good at it. Like we put ourselves out of business in that particular area, I think, more or less.
Like think of even of an oncology patient. I mean, okay, fine. Maybe some early stage cancers you treat with surgery and then the cancer doesn't come back. But what about giving chemo? You don't give chemo one time. I mean, you give chemo and then you get scans and then you see if it's working and then you change the chemo or you don't change the chemo. This is what medicine is in the year 2023. And I don't think our financial model has really adapted to that reality.
Shortcoats, if this episode is worth listening to this far, it's worth sharing. So blast us on your socials. And if you want a sticker for your trouble, send us a screenshot. Thanks.
Also, I think it's difficult when, in terms of finances, we're not compensated as well for things like preventative care and focusing more on prevention of those emergent situations. And I think it's hard because you mentioned in the last episode about how, that phone call to a patient to discuss those test results or responding back or having a longer conversation about some behavior change that they want to make. A lot of times those things are not compensated for in a monetary form from things like insurance companies. And so it makes it harder for providers to do that and to provide good care as well when you're having to meet certain goals and expectations that aren't truly defined in what would be the best medical care for the patient.
Yes. I think preventative care could also be defined as a medical emergency. I mean, if we're just going to broaden the umbrella here, best case scenario, we prevent this chronic illness from happening in the first place by, maybe somebody has prediabetes and they're kind of teetering towards diabetes. You want to prevent that. You want to get to a situation where they're not going to lose their vision or their leg because of uncontrolled diabetes. And sometimes it's not covered, but I would say more often it's just reimbursed at lower rates. Which speaks again to just values, that preventative care tends to be reimbursed at lower rates than a procedure as doing something like a joint injection that's one and done. It's one of the reasons that fewer people go into primary care. I think the reasons for this are really complex, and we talked a bit about it last time. But if you're going to be reimbursed at a lower rate for talking about smoking cessation, than doing a procedure, I understand why people are flocking away from primary care. And I interviewed someone in the book named Alan Glasseroff, who created this clinic at Stanford where I work called Stanford Coordinated Care, which was this innovative primary care clinic where the doctors had 2-hour intakes with patients. They had 1 hour for follow-up. They had a whole team that was co-located in the same place that had a social worker and an occupational therapist and medical assistants who were called patient care coordinators. And they were able to do so much for their patients with that co-location and that team-based care and that time to focus on prevention and to, interview patients, do motivational interviewing with patients so that they can also take control of their health. But one thing that he said was that if you're financially incentivized not to send people to the ER, the system will come up with an answer. And that quote really stuck with me, and that's why I included it in the book as well. They were financially incentivized to do everything they could preventatively to keep people out of the ER. They were getting this upfront lump sum from insurance companies to do whatever it took to keep the patients healthy, to keep them out of the emergency room. And there's not just one way to do this. This was one example of a primary care clinic that I think did it really well. There are other ways, but if the financial incentives say focus on prevention, keep people away from classic medical emergencies, I think there's so much room for creativity, and we will come up with many clinics that follow suit.
I am very fond of, so the two sons wrote a book. It's Chin Med. I'm not sure if you've heard of them. They're on the East Coast, but it's a primary care group that it just started by a father immigrant, and his sons kind of took it over now. They started in Florida. Now they're in like 11 states. And so it's grown significantly, but it's value-based care. And that's their only financial model is value-based care. So they get paid lump sums from the insurance companies for all of their patients, and they focus on geriatric medicine. So they're doing a lot of Medicare patients. And that's essentially their model is how can we create an incentive for ourselves to make sure that our patients are avoiding things like the emergency department, are avoiding these costly procedures. And for some patients, because the model allows it, and it's not fee for service and the patient can actually handle it, for some of those patients, it might mean that they use what I think might be an extreme example, but the patient had like a heart attack. We met with him every single day for a month where we had them in and we were just talking to them and having conversations about how can we do these incremental changes in their lives, right? Like you ate a salad today, that's great. Like you went for a walk today, that's great. These are like baby steps. Because I agree that we have to create incentives and disincentives, right? So like if we think of like rules and laws and stuff as like the field that we're allowed to play in, right? And we as a society decided we're going to make it off limits to just let somebody die without caring for them because they don't have money anymore. That was what Impala does. That's we drew the line there, right? I think that it's reasonable to draw the line a little bit closer and say, okay, you can't skip preventive medicine anymore, or you can't be ignoring this part of the process anymore. I have a hard time, and this is not going to make me friends in the medical community, unfortunately, but so I grew up both in the United States and out of the United States in very low SES communities. And the idea of being able to make the first day, my first job outside of medical school, I'm going to be making the median household income in the United States. Like that's my first job, my first paycheck, I'm already there, let alone when I'm in attending and I'm making, well into the six figures. Even if I'm in primary care, I'm making me, just one person, more than like 3 other families. That's insane to me. And so I have a hard time, and maybe I shouldn't, but I have a hard time when we have conversations as providers, well, I'm not getting compensated enough. Because for me, it's like, I get it. Like, I also want my kid to go to a good school and all this stuff, but at the end of the day, I want to take care of our patients.
But perhaps the underlying statement that when they're saying I'm not being compensated enough is that there's just not enough time in the day to do those extra things that I'm already not getting, paid for.
Yeah.
I want to be a little sympathic to that.
Yeah. And also we have to pay for medical school.
A lot of the burnout comes from how people spend their time. Not that, they're not getting compensated enough, period. Well, I mean, some people complain about that, and I agree. It kind of irritates me. Like, you're getting paid fine. Stop.
Yeah.
But it's more how you spend your time. And, in primary care, we talked a bit about this last time, but just the clerical and bureaucratic burdens that now fall on the physician because of our fragmented system. Like, there was a study that just recently came out that for an 8-hour day in clinic, there's 5+ hours of EMR tasks and other bureaucratic tasks. So it's like you finish your day at 5 seeing patients, but then all the steps to get them the care they need, whether it's clicking through, thousands of buttons in the EMRs, which we talked about last time, faxing records, typing things in a certain way just to appease the chart, doing peer-to-peers, calling insurance companies, all of that stuff typically happens after hours. And so it's uncompensated, just in the sense that you are getting paid to see patients and let's say work from 8 to 5, and all of these hours of tasks are just spilling over into your free time. It's spilling over into your nights and spilling over into your weekends. So I agree. I think doctors are paid plenty. That's not really something that we should be complaining about, or if we complain about it, I'm not very sympathetic to that argument. I am sympathetic to how we spend our time and the amount of bureaucratic work that falls on everybody's plates and how we don't properly outsource this work to either the technology that just honestly should be working better by now, or team-based care, where we have medical assistant support who can be doing some of the clerical tasks that frequently fall on physicians' plates.
Yeah. So if you don't mind, I wanted to, and we could definitely come back to this, but this was like a perfect segue to the other thing I wanted to talk about. When we talk about, so I've read a few books on physician burnout and these types of, and burnout in general, and it seems like one of the big things that people cite is autonomy, that they're a loss of feeling like they're able to do the thing that they feel like they're supposed to be doing, right? So like you said, because they're doing clerical tasks. And one that's frustrating for me as somebody who's maybe analytical to a fault, people don't like what they refer to pejoratively as cookbook medicine, right? The algorithms. One of my favorite stories in the book was the patient, like, I don't know, it was like the monitor or something had like kept flagging that it was a bacterial infection, that it was sepsis or something like that. And you're like, no, it's hypovolemic shock. And I know that, but everybody's like, do you want to push antibiotics? Do you want to push antibiotics? I wonder what you think, especially as we're going into this AI world, like, is there a place for these algorithms and for these programs to be taking away some of those things that we shouldn't be doing so that we can focus on the things that we can be doing? Or are they getting in the way? I guess that's kind of it's a big question.
It's a huge question because the answer is both. And in that story, I felt like I spent so much time wrestling with how to write and how to capture that balance between checklists, I would call it, and then physician autonomy. So yes, people call cookbook medicine, they use that often pejoratively, but a lot of medicine is cookbook, like I'll be the first to say, I don't want to reinvent the wheel every single time I see a case of community-acquired pneumonia or heart failure.
Yeah, like what you think, like 90% of things that you would see in the clinic are going to be easily taken care of using that cookbook, right?
Yes. And so I'm not personally, offended if we have technology take some of that off my plate. In fact, I would welcome that. And I think most physicians should welcome that. I love algorithms. I love the fact that I have certain apps. Like when I started out in medicine, I wanted to download as many apps as I possibly could on my phone that would outsource some of this, basic pattern recognition for me. So then I can focus on higher level things. And so, there was an app where I put in a patient's symptoms or objective findings and it spit out a whole differential diagnosis. And that didn't challenge me, right? Like I just appreciated that existed. And then I could focus on the higher level thinking, which was, well, which one of these differential diagnoses is true and how to work with the patient to look for that. So I think, overall, it's a step in the right direction. It is good to rely on algorithms that can outsource pattern recognition because so much of medicine is pattern recognition. I think historically there has been resistance in the medical community, thinking that only doctors can do this. Certainly machines can't do this, which I disagree with. I think there's a lot of opportunity for machines to take over some of the work that we do. It wouldn't replace physicians. It would actually let physicians work, I believe, at the top of their license. Yeah. And so, one of the stories I told in the book too was about this man who came into the emergency room over and over for the same exact reason. It was that his potassium was critically low. He was born with a rare congenital kidney disease where his kidneys couldn't balance potassium and regulate potassium as they would otherwise. And so when he came into the emergency room, it was, let's say, the 100th hospitalization that he had for this same issue. I didn't want to reinvent the wheel. I was like, great, this all should have been worked out by now. There must be a formula. There must be a treatment plan that 99 others have worked out. So then I can just follow it and get him better and send him on his way and get him out of the hospital. I think the ideal would have been had that treatment plan been worked out. I shared that story in the book because the EMRs made it really confusing and it wasn't worked out. And there was so much trial and error. And it was so hard to kind of piece together his story just from scattered potassium levels in the electronic medical record that there wasn't a magic formula. And so I think there's a lot of potential for AI in medicine to do what I hope that technology should have been doing thus far, which is to offload some of that low-hanging fruit. Obviously, it really depends on the accuracy. And if it just starts generating a bunch of errors, it's going to create more manual labor for physicians to then sort through and separate the wheat from the chaff. And I think that would be the worst case scenario. But I think best case scenario is that some of the pattern recognition is offloaded from physicians' plates.
How do you, as a clinician, faced with for instance, in this particular anecdote of the machine that was suggesting basically the wrong thing, how do you, I guess you know from your experience that it might be the wrong thing, but I imagine that there are sometimes recommendations given by these machines that are almost right, like they're along a spectrum, but not quite what you need. And I guess I'm wondering, like, what kind of interface are you provided to distinguish between the thing that's almost right and the thing that you actually need to do, or do you just use your brain? Like, does it say, does the machine say, hey, I think, I've got a 65% chance that this is X, and you're like, no, that's Y. How do you, as a clinician, figure that out?
You still have to use your brain.
Yeah.
You cannot offload your brain or outsource your brain. And I think the story that Jeff brought up is, kind of the perfect example of that, where it was the electronic medical record that was flagging a case of sepsis because this patient had low blood pressure, a fast heart rate. I think they were breathing quickly. And so I was on call that night, and I was paged to a rapid response to lead a code sepsis. And then, when I got to the bedside, it was a woman who had been bleeding, and she had low blood pressure, fast heart rate, and fast breathing because of the loss of blood. And it was like this whole team of cavalry ran into the room with me. And the initial thought on everybody's mind was code sepsis. It was like, follow whatever the algorithm and the EMR had alerted us to. And I just remember, like, I wanted to pull my hair out when multiple nurses were coming up to me and being like, Doc, do you want to start antibiotics for the sepsis? And I was like, no. Yeah. This patient is bleeding. And one of the nurses asked me, this is not to, say the nurses did anything wrong. It was just the initial thought when they ran into the room and everyone was trying to help. One of the nurses had asked me, well, like, Doc, how do you know that it's a bleed and not sepsis? And I think I said something in the book, like, it was like looking at a chair and being asked, but how do you know it's a chair? Like, there was a pile of blood in front of our faces and everyone was still looking at the EMR that had been flagging us to code sepsis. And so it was very easy to run into that room and turn on your brain. Yeah. And just, look at the pile of blood on the floor and be like, the most important thing actually for this patient is to get blood. Now, I also argued that the code sepsis was a good thing. Like, even though the algorithm got the details wrong of what kind of emergency it was, it got the details right that it was an emergency and we all needed to run into the room and we needed a lot of people to help this patient. And so it alerted us to the fact that we needed to use our brains. And I think, actually that might have been a pretty good division of labor there in the end.
Well, you made it to the second break. You tolerate us. If you can, consider donating or buying a sticker or something. Visit theshortcoat.com and help us do stuff without having to beg a dean for money. Thanks.
I guess the thing that concerns me about this story is that I find that people find it easy to take what's directly in front of them and run with that rather than thinking through all of the different possibilities. One thing, I guess that concerns me, that differential diagnosis process might just get accidentally tossed out the window because people tend to believe what they read. So, the training that you need to receive about these algorithms, and I'm sure you do, is, how to distinguish between a pat answer and the real answer.
I guess to be fair to the algorithm, how many medical students or interns or residents have been like, I'm like pretty sure it's this, and the attending is like, you were close, you were in the right area, but no, it's not. You missed a crucial detail. Yeah, so like, I expect that AI is not going to get it right 100% of the time. I also expect that we don't get it right 100% of the time.
I mean, maybe the answer is to treat the treat the algorithms, treat the AI as a earnest intern, and at least for now, an earnest intern who, is reasonably competent for an intern.
Yeah.
Not like
the actual expert in the room. Like,
right.
He knows a lot, but he's not the expert kind of thing. Like, or it, I guess I shouldn't anthropomorphize a machine.
Well, it's inevitable, man. We're going to,
we're already there.
Like you were going to say.
I think it spits out, the AI or the algorithm can spit out a differential diagnosis, but it still takes you as the clinician to look through that differential diagnosis and say it's this and not that.
Yeah.
But the benefit of spitting out that differential diagnosis is it might alert you to something that you just forgot. We all have our own biases. We might be biased by cases that we've recently seen, and we just see something similar and we think, oh, it's this. We all have confirmation biases. I think there's value to spitting out something that's thorough. So then you can sort through and use your brain about what the most likely possibility is.
But is that what these algorithms currently do? I don't know.
Some of them do.
Okay, good.
So that app I brought up, it's called Isabel. Like that's the one that you plug in a patient's symptoms that I use my intern year, and it spits out a differential diagnosis. And I was like, I remember thinking, malaria. I didn't think of that. Like it wasn't malaria, but it came up with a differential diagnosis that then just helped me, I felt, be thorough and not miss anything.
And I will say that's how I've used like programs like, for example, GPT or any of these chatbots. When I've used them to help me with my studies and stuff, that with the right prompt, you can say things like, give me a broad differential. That's because that's what I want, right? I want to be able to look at all of these things and consider like you said, like, oh, I didn't even consider malaria. Even though it wasn't malaria, this is something that maybe down the road, like I should be able to consider that,
Right. Yeah. It kind of reinforces that pattern recognition in some ways. So like the things that you don't think of normally because of your own biases, like all of a sudden it's there and it's like kind of poking you. And that's positive in some ways. Yeah.
That's where I feel like it can be a really helpful tool when created, and we just need to make sure that people don't become reliant on, there's one answer and it has to be right. Because like you said, you still have to turn on your brain. You still have to think through, because people are human and they don't always know what to tell you that's important about their story. Mm-hmm. So there might be other things that you don't even know about yet. And similarly, AI doesn't know about that. So if they can generate a list of things to get you thinking, then you can take that initiative and ask additional questions and try and figure more things out just to be as thorough as possible.
I will say, though, that my thought, and feel free to interject here, you have much more experience in the field than I do, but I have this sense that there are a lot of people that are, like I said, they're kind of hesitant when it comes to like the cookbook medicine and the algorithms that we use, that we go through already in our heads. They're like, think for yourself, don't just go down the checklist, right? Which is fair, because every patient is unique and the checklist is a good jumping off point, but isn't the end all be all for every patient. Patients don't neatly fit into all of our algorithms, unfortunately. I think that a computer generated algorithm is more or less the same thing, where it's like you have a valid point, which is you don't just accept it as gospel fact. But at the same time, if it gets us closer and then from there we can branch out, I think in the long run, that's going to be better for our patients.
I agree, but you guys are all talking to a millennial physician here. Maybe if you were interviewing an older generation, the opinion would be different. Like I welcome any tech support that would get us closer to treating patients better.
I have a friend he's an intern at Yale right now. I'm a former Iowa student, and I was visiting with him recently, and he was telling me, we've got an AI that is integrated into the EMR now. And he's like, at first I thought it was going to be the worst, but it kind of helps with broad differentials. It helps pull things from, like you said, when you've got 99 visits before this for this patient and you're trying to like scramble through the notes trying to find what's actually relevant and helpful, and you can't because it's so confusing and jumbled. I think the idea of an AI that might be able to pull that stuff, the more relevant stuff, to read those 99 notes, that would be great. I would love that.
Yeah.
I think taking a step back, from my vantage point, the best use of AI in medicine is actually helping with all of this administrative garbage that physicians and other healthcare workers are all currently dealing with.
Sure, like maybe taking a transcript.
Electronic medical records that are scattered everywhere.
Yeah.
And it's pulling together, maybe a sentence or a paragraph about what's actually going on with the patient. It's cleaning up the messes of the old tech and taking the clerical work off our plates.
Yeah.
Like maybe taking a transcript of the encounter and coming up with a draft of a note or something like that would would be even.
Yeah, that's the perfect use. You know, that's not working at the top of our licenses to be doing that ourselves over and over.
Right.
You know, my concern about this, I mean, there's many, but one of my concerns about this is that we are going to end up spiraling, making worse, basically exacerbating a situation that we already have now. Like, I'm old enough to remember, you know, when paper charts were converted to electronic medical records, and they promised they would already be doing all of this stuff for us. And they promised that it would take clerical work off doctors' plates, but then the opposite happened because the EMRs were just able to generate so much noise. And my concern about AI is just the ability to generate even more noise at higher volumes and faster, further cluttering an already very cluttered electronic ecosystem, and then resulting in more manual labor on healthcare workers' plates to separate the wheat from the chaff. You know, I think that's the worst case scenario. But again, going back to the best case scenario, it removes the clerical work from our plates. It takes on so many of these tasks that the technology had promised to be doing for us so far, and it just hasn't been.
I think the other thing that I often think about when they're like, oh, you know, AI is going to solve these problems and make it easier for us. Historically, you know, technology has freed up time, but it's also, we also tend to fill up that new time with other things once we've got it. And maybe that's not, I mean, that's helpful in this situation, but also like it's possible that the powers that be would see, oh, these doctors have all this new time. Now we're going to make them do X, Y, and Z that's outside of, you know, it's what we want them to do, but it's outside of their
That's fair.
expertise.
I would also just argue it can't be worse than what's already happened. So much of our time is spent on things that are not doctoring.
Yeah.
I guess my hope is, so I talked to a doctor who practiced in Europe and then is now practicing in the US, and they talked about the difference in the length of notes that doctors write, and how in the United States it's just, they're like novels. Like, we're writing books over here compared to what they do there. And there are a lot of reasons for that, right? But yeah, I guess I would be concerned that AI might perpetuate that or exacerbate that, right? But I think that, for me, kind of highlights one of the most important parts of this. And I think maybe a big part of your book, which is that it's not just we need to use these tools and these tools are going to make our lives better, which hopefully they do, but we also need to be looking at the rules of the game. We need to be looking at how we are designing the system. And I think that we need to make sure that physicians, clinicians that are part of using that are helping the patients, they need to be in the rooms having these conversations about, yeah, of course we want AI and the EMR to help us clean this up or to unclutter it. This is how it should be, because this is how it's going to help my patients, right?
Yeah.
Those kinds of conversations.
The best way to use this tool.
Yeah. I think that I don't want to put the blame on my future coworkers, but I think that we as a field certainly have room to take responsibility for how our systems are designed to going forward to make sure that they're better for ourselves and for our patients.
I think that was perfectly put. And I argue in the book that so many innovations that we need to get to in the tech sphere, the biggest barriers there are not actually technologic barriers. Sure, there are technologic barriers, but we have to understand the underlying incentives and the underlying design problems that got us to where we are. And so, you know, just a quick example, the notes are getting longer. Let's say something that maybe you already have experience doing when you see a patient is you have to chart something called a review of systems, where you are asking a patient like this whole litany, this whole checklist of things that they don't have, even if they're there for something like a cold. You have to be like, no neurologic symptoms and no home symptoms and no, you know, et cetera, et cetera, et cetera. And if we design the tech to be writing these notes for us, well, I mean, that's great because we don't have to write 14-point review of systems negative and add all that clutter, but somebody else is adding all that clutter. It's the AI. And we would have to go back to why we need to put all of that into a note in the first place. And that's not a tech issue. I mean, that's a design issue. That's an incentive issue. That's a billing issue. It's why it's getting back to working with insurance companies too. And like, why do you need all of this stuff in order to bill for a patient visit? And so there need to be a lot of different stakeholders at the table. It's not just physicians and programmers. It's physicians, programmers, insurance companies, patients, family members. And I think everybody needs to be working together to be able to redesign systems where the tech can just not exacerbate some of the underlying issues, but actually help clean things up.
Yeah, I definitely agree with what you're saying there. I think a lot of, or what you just said previously, where you're saying, you know, doctors are spending a lot of time doing things other than doctoring, right? And part of making the system not so fragmented is going into all of these other spaces outside of medicine, like law and like tech and like, I don't know, social work and education and like humanities, all sorts of things, right? That as one person, like, there's a reason why I did not go to law school and decided to go to medical school, right? And we can't be expected to know all of these different fields well enough to make like appropriate change. And so I wonder, like, who are the people that are helping you with this? Like, who are the people that you've been able to reach out to? Who are the types of roles that you've been able to reach out to besides those, like there are the people that are advocates, right? Like, you are an advocate and a doctor. But like, are there specific roles that like make more sense to reach out to? I guess I'm just wondering, like, who's the team? Who's working with you? Who's been helpful?
I think one of the most important members of the team are patients. Patients know the system best. Patients are the ultimate, users. Like, if we're talking about tech and looking into making it user friendly, like, who are the users? They're patients and loved ones who have to navigate the system. Other members of the team are all the members of the healthcare team. It's doctors, it's nurses, it's social workers, it's physical therapists, it's pharmacists. And it's then the coding side, it's the programmers. And I think all are important members of the quote unquote team, and all can be advocates for a better system. But many people kind of do just look at it from their own silo. And it's important to communicate across those silos so that we can create systems that work better for all the users involved.
I guess one of my biggest concern is that when we say over and again, I just want to be a clinician. I just want to be practicing medicine. I don't want to do all of that other stuff. I just want to do this. I'm worried that the more we say that, the more we make it impossible to actually do that, if that makes sense. If we leave all the decision making on how everything else is organized around us to other people, they're going to put things on us that we don't want. Hence 5 hours after seeing patients of doing clerical work instead of taking care of patients, because we have decided, this is all we want to focus on, and we're not going to be the ones in the rooms making decisions.
In order for that to be a reality, in order for that wish to be a reality, you have to step up first.
Yeah.
And become part of a system that figures out how to solve that problem.
I think there are some things that
you're already working outside of in doing that, you're working outside of being a clinician naturally.
I think we rightfully outsource many things. They should be outsourced. And I think that there are some things that can't be outsourced that are not necessarily being a clinician in order to be part of that larger team that's making the change, right? To be part of those conversations.
I think you make a good argument for why there need to be more physicians in leadership positions within hospital administration. But that being said, the whole idea is there are certain people that want to do that, but then there are many clinicians that don't want to do that.
Yeah.
But you have your advocate, you have someone who understands the system within that position of power that then can help let you be a doctor and do just what you want to be doing, which is doctoring. I don't think when people say, let doctors be doctors, they're saying they don't want to be involved in hospital administration decisions about how we spend our time. I think, we're saying we don't want to be doing paperwork.
Yeah.
We don't want to be faxing. And I think that with more physicians in leadership positions, there can be a trickle down to everybody else so that they can be focusing at the top of their license. The last thing I'll add about that is that, all of these bureaucratic tasks that we've talked about, they are the number one source of burnout for doctors. Like, it's not just keeping medical students from going into certain fields like primary care. It's taking people who've been practicing for 10 years and they're quitting and they're taking non-clinical careers, total waste of their expertise and all of that training. They're so burnt out from sending faxes that they're leaving medicine entirely. And so everybody loses when that happens.
Okay, so
I think it's
outlaw faxes.
I think it's so interesting that the AI that we're designing and even that we're talking about is working towards replacing the physician work of the doctor, making differential diagnoses, and not the actual problems with being a doctor, the bureaucratic side. And I wonder, who do we need to explain those problems to shift the focus of the AI that we're designing?
Me, us, right now. I mean, that's why, going back to what we said earlier, I mean, honestly, I feel like we do say this a lot, or I'm trying to spread this message a lot, that when I hear people talk about AI in medicine, it is often about replacing the doctor work. But, the biggest thing that's affecting doctors right now, in my view, and affecting patients, is the fragmented healthcare system. It's the administrative tasks that are required to navigate a fragmented healthcare system. And it's just such a huge issue for so many reasons, in terms of medical errors, in terms of burnout, in terms of burdening people, in terms of exacerbating health inequities for people who can't navigate the system. The best use of AI is administrative nonsense that doctors and patients are currently doing. And I really do firmly believe that. I think before we even talk about AI's role in helping us generate a differential diagnosis, it's solving a problem that's just not our biggest problem. It's solving a problem that maybe is number 100 on our problem list. The biggest problem facing healthcare today is that it's fragmented. And because it's fragmented, there is a ton of administrative red tape to cut through in order just to get care going. And that's where I think AI can help us the most. And I think I can end on that soapbox.
Mm-hmm. Excellent.
Yeah. Well, great. Anything else we want to? I feel like we've still
have so much
gotten only partway through this, but maybe
my listeners are going to get really tired of.
I was going to maybe
I
you
do
have
this for me. I'm not going to get tired of you, but I'm happy to let you have the last word on that one today, because that was an excellent place to end.
Mm-hmm. Yeah. Well, that's our show. Jeff, thanks for producing today's show and bringing Dr. Yurkiewicz back.
Happy to do it.
Appreciate that. Fallon, Jacqueline, Alex, thanks for being a part of it.
Thanks for having us.
Anytime.
And what kind of rapscallion would I be if I didn't? I love that word. What kind of rapscallion would I be if I didn't thank you, Shortcoats, for making us part of your week? If you're new here and you like what you heard today, follow us wherever you get your podcasts. The show is made possible by a generous donation by Carver College of Medicine Student Government and ongoing support from the Writing and Humanities program. I'm Dave Etler saying, don't let the bastards get you. I forgot our music. It's all right. I say it every week. Nobody listens. Nobody gets this far. I'm Dave Etler saying, don't let the bastards get you down. Talk to you in 1 week. Hi, Shortcoats. Look, life in medical education, life in America, life in the world is often difficult. And I often wish I could help. All I have is this podcast, but in my wildest dreams, you have the support you need to lead a life of your choosing. You deserve to be happy, healthy, and successful in whatever ways you define those words. So if you need support because you've experienced racism, discrimination, harassment, mental health crises, I want you to be able to get the help that you need. And so I'm going to put some links in the show notes to some resources that you can use. But the bottom line is that, for what it's worth, I see you. I know you're out there. I wish I could do more. Maybe I can in ways that I don't understand yet or know about. But I see you, and I'm glad you're here, and other people are too. This Shortcode podcast is a proud member of the MedEd Media Network. Inspiration, information, and guidance on your journey to medical school and beyond at mededmedia.com.